short now, is single rooms in ICU, and I consider this to be an example of infection control by design. So, no, I'm too scared now. So, in 2005, we started planning for a new 750-bed university hospital on a greenfield site here on the Gold Coast. And a number of factors influenced the infection control design components of this build. In 2013, we moved into this magnificent facility, and I joined with my colleagues who work in this fabulous place and share it with pride because of all the work and effort that went into it by everybody involved. But it was a long journey to get from 2005 to 2013. Personally, some of the factors that influenced my colleague John Gerard and I in terms of the planning and the design of the hospital from an infection control point of view were, first of all, some PhD study that I completed in 2005, which was an ethnographic approach looking at the clinical culture in a variety of wards and departments and how that impacted on infection control practice. John and I had the opportunity to visit some international hospitals. We went to the University Hospital in Geneva in Switzerland and met with Didier Patet and his group over there, who are the world leaders in improving hand hygiene and who provided advice to the World Health Organization that resulted in the 5 moments for hand hygiene that we now practice. We went to England and had a look at some of the hospitals there. The NHS was ahead of us, and they had actually embarked on and completed a lot of their infrastructure programs, and so we had the opportunity to meet with infection control staff and other staff in these new facilities which were now occupied. We had the opportunity to talk to the staff about the strategies and the design elements that they'd implemented when planning and building their facilities, and now that they were using them, to see how successful or otherwise they'd been. In 2009, while all this planning was going on, when we needed not another single thing, we, like everybody else in the room, had to deal with the influenza pandemic. And the influenza pandemic in our health service had a major impact on the infection control and infectious diseases department. It also had an impact on the intensive care unit and places like maternity and some of the medical wards. And it taught us or showed us firsthand what the challenges of dealing with large numbers of people with an infection were actually like. And the final influencing factor was the accumulation of 30-plus years experience combined between John and I in infection control and infectious diseases and the challenges that that involves. Of course, there were other influences on the design, and these are the standards and guidelines that we have to comply with. And these standards and guidelines, as they relate to infection control, really incorporate or are based on these principles. Clearly delineated workspaces that have specific purposes. And this underpins appropriate workflow, so we're not working from dirty to clean, but clean to dirty. We want the environment to be clean and cleanable, so we look for smooth, fluid, impervious surfaces. We want to incorporate engineering controls where it's appropriate, such as negative pressure or positive pressure air handling. And we want to integrate infection control cues into the design. Going back to the PhD work, as I said, it was an exploration of the culture in the clinical area. And Patton says that any human group of people interacting together for a period of time will evolve a culture. And Goodenough talks about what he thinks culture is, and this is a bit of a paraphrase. It's a collection of behaviour patterns and beliefs that constitute standards for deciding what is, what can be, how one feels about it, what to do about it, and how to go about it. And when we think of culture, we often think of ethnicity and Australian culture or culture of particular groups of people. But many people fail to think about the culture that is developed amongst clinicians who work together in a space over a period of time. And spaces themselves have cultural meaning and can influence behaviour. And just by way of illustrating that, if you were to be in a cinema like this group of people are, there's a whole bunch of people here, most of them won't know one another, they're all sitting side by side, and yet they will all usually comply with certain specific standards of behaviour that they agree on silently are approved. Certainly once the lights go down and the movie starts on the screen, people will be frowned at and shushed if they're still talking, and God help you if you leave your mobile phone on and it rings at a crucial point in the movie. Different kind of behaviour, though, is what you would expect and approve and find on the football field or in the stadium of the sports field. So here people will be talking amongst themselves continually, and they'll spontaneously stand up and wave their arms and shout and cheer, and all of that is considered appropriate and approved as long as it's congruent with what's happening on the field. That same behaviour, however, would be distinctly frowned upon in a waiting room. So when you think about spaces and the cultural meaning and how that meaning influences behaviour, think about it now in terms of the clinical context. Do the same kind of things apply? Let's have a look at the operating room. So in the operating room you can see pretty clean lines, a large space. You can't even see the patient, right? The patient's in there somewhere. But people are very focused over a particular area on a particular patient in a particular space at a given time. There are definitely behaviours that are expected in the operating room, and if you think about it, some of the things are like the very ritualised hand hygiene that occurs, the scrubbing. It's very ritualised and people recognise it and see it and expect to see it. This brings into play the concept of surgical conscience, such that in the operating room people are actually on the lookout for breaches in infection control and will and are expected to speak up and say, you've breached there, you've contaminated yourself, you need to go back and scrub again. In the operating room space we have usually in one room a single patient, a single room, a single procedure. We have a clear delineation between episodes of care. So when this patient's care is finished, this procedure is done, that patient will be removed from the room, all evidence of that patient having been there will be cleared away, and the room will be prepared for the next episode of care. So it's very clearly delineated. And it supports the clear workflow from clean to dirty. So in the operating room, for lots of other reasons as well, infection control practice is well supported. This, on the other hand, is an ICU MultiBed Bay. We can only see a couple of the beds in this slide, but you can, if you think about it in comparison to the operating room, it's really busy. There's more than one patient. The patient is still hard to see, although easier to see than in the operating room, but they're still hard to see because there's all the technology around. There's no clear delineation of space. Even the relatively solid divider there is pushed back. So there's nothing impeding movement from one patient to the next patient. So again, no clear delineation of the episode of care either. In the ICU space, technology tends to dominate the landscape, and it has the loudest voice. It has the flashing lights, the buzzers, the alarms, and it speaks for the patient, so it needs to do that. But that's what we hear. That's what is most dominant when you walk into the room. As I said, there's no clear delineation between patient spaces or between episodes of care. Multiple activities simultaneously occur involving a number of patients. And also there's the distraction of the busyness of whatever else is happening in the unit. So how can infection control be supported in this environment? What we thought needed to happen with the design of the hospital was to try and integrate some of the infection control components and elements into the environment and therefore into practice. So things that we really wanted to affect were hand hygiene, appropriate use of personal protective equipment. We wanted a clean environment that not only was clean to start with but was easy to maintain in a clean state. We wanted there to be ample opportunity to effectively and consistently apply the principles of asepsis. We wanted to accommodate patient isolation as required and also to be able to accommodate transmission-based precautions. So by having all single rooms in our unit, we were able to play around with the placement of the alcohol-based hand rub. It wasn't left to wherever we could put it after everything else was done. We could clearly make decisions about where that would go, and we could place alcohol-based hand rub in multiple sites if necessary. There was a hand basin in every single room, so you didn't have to cross the corridor or pass 3 beds and 3 patients to get to a hand basin. We made sure that the personal protective equipment was available and accessible. We tried to ensure the most minimal number of horizontal surfaces, so there was less accumulation of dust. We used things like wire baskets so that dust wouldn't sit, it would actually fall through and go to the floor where it would be picked up. And again, as I said earlier, we really focused on smooth, fluid, impervious surfaces. We tried to make sure that in our single rooms there was space to accommodate procedures. No longer were you having to pull the curtain to undertake the procedure on the patient with the machines already all around it and then try and juggle in a trolley, set up a sterile field and maintain it with the curtain draped across that or across your gown or gloves or whatever else it was you were trying to maintain. Each room is in and of itself a standard isolation room and delineates one episode of patient care from another. It is a physical barrier, a physical cue that you are leaving this patient. You have to pass out that doorway and then walk into another doorway before you get to the next patient. So this gives infection control a voice similar to the voice that the technology has in the unit already. And all rooms, because they're standard isolation rooms, allow for transmission-based contact and droplet precautions, and one room in each of our pods is a negative pressure room as well. This is what the room looks like, a typical room looks like without the patient in it. You can see that the bed would go in there and then all of those monitors and so forth would come in around the patient. Clean lines, still too many horizontal surfaces, but needs must. And it's light, it's airy, and we really like it. So in terms of evidence, is there any evidence around the efficacy of single rooms in intensive care for preventing infection? There really isn't a lot of evidence around it. There were some studies, but they weren't well designed. In 2011, well after the plans were approved and the building had commenced, Telch and Hanley published an article based on their work where they moved an ICU from MultiBed bays into single rooms, and so they had infection rate data before and after that move, and they were fortunate enough to have another ICU located in the close proximity within about a kilometre and a half that they used as a control. So what they saw was in the control there wasn't really any change in the infection rate data, but their adjusted rate of acquisition of Clostridium difficile, VRE and MRSA combined decreased by 54% in the new single-bed unit, single-room unit. Not only that, we have epidemiological evidence. Every single speaker today before me has talked about source control and patient isolation. We know that when we're trying to prevent or stop transmission of infection, source isolation actually works. What we also know, though, is even if we have screening programs to identify patients who are positive for VRE or MRSA, for example, we have to collect the samples and we have to wait at least 48 hours before we get results. And we always encourage our staff to collect the sample as soon as possible after the patient arrives, but at least within 48 hours. So there's potential for the patient to have been in the area for 4 days before we get a result and recognise that we now have a reservoir for that organism. So were we successful? What are our results? This is a graph depicting our ICU-acquired MRSA and VRE by month from 2000 to 2017 up until August. It's busy and we can do better. So let's have a look at this one. These are the same data that demonstrate acquisition on a yearly basis over that same period in time. I will say that this represents both colonisation and infection. A lot of the positive results are picked up through screening. But we know if a patient is colonised with a microorganism, there are two possibilities or two risks. One is that the patient who's colonised develops an infection if that organism is translocated via the hands of healthcare workers or contaminated equipment, or through invasive devices on that same patient, and the patient themselves also acts as a reservoir for those organisms to be picked up and transmitted to other patients in the unit. So even colonisation is of concern. Recognising that our number of beds in ICU have increased from the old hospital to the new hospital, we looked at the data, or a section of the data, from 2012 to 2017 in terms of acquisition per 1,000 bed days in our ICU. And, you know, I'm pretty happy. I think we've been pretty successful. We didn't just put lots of single rooms in our ICU, we put them throughout the hospital, and so similar data follow for the whole hospital. This is an interesting slide to me because it shows the cumulative effect of a range of strategies that have been implemented over time. In 2009, we implemented alcohol-based hand rub throughout the wards. It was already in place in ICU and had been for many years, but from 2009 it started to be used in the wards as opposed to having to go to the hand basin and perform hand hygiene. In 2013, at the beginning of 2013, we implemented a multifaceted hand hygiene compliance improvement strategy which helped, and then in 2013, towards the end, we moved out to the university hospital with the single rooms. And this is the same, these are the same data from 2012 to 2017 per 1,000 bed days, acquisition per 1,000 bed days across the hospital. So is it pointless or worthwhile to put single rooms in our intensive care unit? Well, I just want to use some data produced by the Australian Commission in 2008. And they say that infections caused by MRSA result in significant morbidity. Mortality from MRSA bloodstream infection ranges from 10 to 50%. High rates of MRSA result in increased vancomycin use, which in turn results in increased risk of selection and amplification of VRE. Just looking at 2 outbreaks of VRE in Australia, one small one in South Australia involving only 9 patients cost $173,500 to control. A large outbreak in Western Australia involving 169 patients cost $2.7 million to control. So if we can prevent that occurring in the first instance, is it worthwhile or is it pointless? This is my final slide, and it's another image from our magnificent hospital. And when I saw it, it reminded me that good environmental design can influence behaviour and guide good practice. It provides better care, better outcomes for patients, it saves health dollars and reduces antibiotic resistance. In my view, win, win, win. Thank you.